Okay, good morning, everyone. Welcome back to our grand rounds. It's one of our most popular rounds of the year. It's the Uveitis Potpourri. We always get great reviews from faculty and residents about this particular session. I'd like to welcome our faculty host this week, Dr. Larissa Dershko, who many of you are already familiar with. She is Chief of Ophthalmology at St. Joe's, which is now part of Unity Health, and has previously served as the Uveitis section head for the Department of Ophthalmology and Vision Sciences at the University of Toronto. She is an award-winning ophthalmologist and surgeon, having won the Michael O'Shea Award for her work with residents at St. Mike's. So, Dr. Dershko, welcome. Thank you for making the time this morning to deliver Grand Rounds, and we look forward to the presentations you guys have prepared.
Thank you very much. So I would like to welcome everybody as well, and warm welcome to Francesco, Dr. Pichi, who is joining us. He's just arrived in Canada. He's our new uveitis faculty at UofT. So this morning, we're going to put all those skills that you learned at Sally Lutzum to the test. Our residents and fellows have prepared 4 mystery cases. And so we'll highlight key questions and clinical dilemmas in the diagnosis and management of posterior uveitis. So please participate in the polling questions and ask questions as we go along. Hopefully we'll have a few minutes at the end of each session for some audience questions. So we're starting off with Dr. Pereira, and he will present the first case.
Awesome. Thank you, Dr. Dershko, for allowing me to present this interesting case, and thank you everyone for coming early on your Friday morning to hear our interesting posterior uveitis cases. My name is Austin Pereira, one of the clinical fellows at the University of Toronto for medical retina and uveitis, and this is a very interesting case I saw with Dr. Dershko in my second month of fellowship, and I'll keep the case a little bit secret for right now so we can discuss our findings. The patient presentation was a 30-year-old female who was referred to our care by a Sudbury ophthalmologist up north for bilateral uveitis refractory to topical steroids, as per the referral note. So on history, the patient noted that over the past year, so 12 months, she has been managed by this local ophthalmologist for anterior and intermediate uveitis with both topical and oral prednisone. Her initial symptoms 12 months ago were really primarily floaters, but she had a bit of red eye and some eye pain, but really the floaters were the most debilitating symptom. She did note that she had persistent floaters and now some more blurred vision over the last 6 months since she presented to us. Her presenting prescriptions were Predfor 3 times a day, Max-Dex cream at night, and Timolol twice a day for a mild IOP reaction. She had 2 courses of oral prednisone over this past year. It started at 100 milligrams, a high dose, and tapered by 10 milligrams weekly. So 2 courses of this over the past year. Her past medical history was significant for major depressive disorder, of which she was on bupropion. Also, again, she had those 2 prior oral prednisone courses, but she's not currently on oral prednisone. She had no past eye surgeries, lasers, or injections. And on review system, she was a Caucasian HR manager born in Canada, no recent travel, and pretty much a completely unremarkable review of systems on the typical questions you ask on history. There was real no pertinent pauses that we were able to elucidate on review of systems. On examination, her best corrected visual acuity was 20/30 and 20/25, and this is primarily to a bit of lens change that was occurring over the last 12 months due to this topical steroid. Her intraocular pressure was normal. She actually had no KP, but she did have 1+ AC cell and actually 2+ vitreous cell, but no vitreous haze. And here we have the fundus photographs, so Optos wide field color photographs. And really, you can see most strikingly, you can actually see clinically some sheathed vessels in zones 2 to 3 in the mid to far periphery with a little bit of that tortuosity of those venous vessels. But really, you have a good view with no haze. The nerve looks mildly maybe hyperemic, but relatively unremarkable. And here we have the fundus autofluorescence. And the fundus autofluorescence is also a little bit bland. You have the normal foveal hypoautofluorescence signal, but you have in the peripheral macula some focal areas of hypoautofluorescence, but in the mid to far periphery, the expected autofluorescence signal. And the OCT maculas demonstrated normal foveal and peripheral macular lamination with no fluid or any signs of any vitreoretinal pathology. But the first real striking finding here was a OCT of the RNFL on the optic nerve head, and you can see that the average RNFL thickness was increased in both eyes in keeping with bilateral disc edema, which correlates to the hyperemic nerves that we saw clinically. And now we have the IVFAs, which really tell the story here. So I can't really see who's in the audience here, but in our residence, but maybe Heba, she's always at the front there. Heba, do you want to try maybe taking a stab at interpreting these IVFA images? She's our budding retina uveitis specialist in R3, so I think she's got this.
Sure. So this is an IVFA. It's an early of the right eye showing disc hyperemia as well as vascular leakage of the large vessels from zones 1 to 3.
Yeah, maybe a little bit of maybe leakage, more vasculitis there. It's looking a little bit angry in the early stages here in the right eye. I agree. So here's that hyperfluorescence that Heba perfectly described, and a bit of that angry vessels there in zones 1, 2, and 3. Here's a montage of the mids, and Heba, stay with you. I'll ask you another one of the lates. But here you can really see in the mid photographs in the right eye, you can see again disc hyperfluorescence, and really most strikingly some capillary leakage. In zones 2 to 3, 360 in this montage. And here those arrows are really highlighting that capillary leakage. And here are the late IVFA images in the right and left eye. And Heba, if you're still with us, do you mind if you describe these as well?
Sure. So again, you see in the late phases, you see that disc leakage, and then you also see more capillary and small vessel leakage, and you see also peripheral leakage 360.
Wow, that's incredible. So thank you so much, R3, amazing. So yeah, that disc hyperfluorescence and that can keeping with leakage, as well as that small vessel leakage and capillary leakage that we saw in the earlier phases. So really to summarize, we have clinically sheathed vessels with a relatively bland FAF and OCT macula, but an OCT of the RNFL demonstrating bilateral disc edema, and an IVFA showing bilateral disc leakage and vasculitis in zones 1 to 3. So at this point, we can diagnose this patient with bilateral panuveitis with retinal vasculitis that has been refractory to multiple rounds of oral prednisone. But just as the patient was about to leave the room, she said, by the way, I don't know if this is important. And as any uveitis specialist knows, anything is important on their review of systems or history, so she had my attention. And she noted that my tattoos have been acting strange since it's been happening. Again, I asked the patient about new rashes, but I didn't specifically ask her about any tattoos that may be acting up. And you can really appreciate it on the photographs that she agreed that we're allowed to share for this talk, that these tattoos are really elevating out of her skin. They're supposed to be flat, flush against her skin, but you can really see on these left photos and really here that it's starting to scale and they're elevating out of her skin. And she specifically noted the minute she first had her symptoms 12 months ago, and every time she's had a flare, her tattoos started to flare up. They started to elevate out of her skin. Here's a video she agreed to share that's anonymized. And you can see that this tattoo, there's not supposed to be striations here. It's because the ink is actually pushing out of her skin. They're not too red and indurated, maybe a little bit of redness, but really it's the elevation of that ink that's causing her trouble. And it really was always after her oral prednisone, it settled down. So I went back to the review of literature and I looked up something called tattoo-related uveitis, and if you can believe it, there is some literature on this. It is a rare condition where patients present with a granulomatous reaction of tattoos in their skin, as well as panuveitis. There was a beautiful review, it was actually published in a dermatology journal by Kluger in 2018, and at that time there was only 39 documented cases in the literature of tattoo-related uveitis. That's probably due to underreporting. But the prevalence of this tattoo-related uveitis is increasing as about 25% of North Americans now currently have tattoos. And there's 3 current categories of disease. First category is cases with systemic sarcoidosis. So they actually have sarcoid-related like non-granulomatous lesions or maybe in the hilar adenopathy, but they have upwards of 80% of ocular involvement in these cases. The second category are patients that just have isolated tattoo granulomas. And the third is uveitis after tattoos, but with no skin involvement. Now, what's the current pathophysiology? Again, it's not too well known of a disease, it's quite rare, but the 2 current thinking is that the first is a delayed hypersensitivity to the tattoo ink itself because the tattoo ink can introduce this large antigenic load ultimately triggering a downstream uveitic reaction. And the second is a bit more of a mild antigenic response to the tattoo, but in patients with known sarcoid susceptibility. So you have the positive ACE or known sarcoidosis. This can lead to that granulomatous reaction of your tattoos. And here's a picture from that publication where you can see these tattoos are really elevating out of their skin. They have a good thickness to it. It feels like, in one of the words she really struck, I remembered, was she said it felt like braille, really elevated out of the skin. And this is heavily related to sarcoidosis due to some of these patients having non-caseating granulomas on their skin biopsy. Dr. Kaplan, I don't know if he's here in the audience, but he has a couple of patients who he actually sent to Mount Sinai Hospital dermatology during a flare, and they had biopsies of their tattoos, which demonstrated non-caseating granulomas. But what about our patient? She had a completely normal workup with normal CBC electrolytes, normal TB, no TB or syphilis signs on the serology. And for the sarcoid workup, normal ACE, and the chest x-ray was normal, which was great. HLAs were normal at this time for birdshot, Behçet's, HLA-B27, ANCAs, and rheumatoid factor all negative. However, one thing did come back positive: urine beta 2 microglobulin. So, is this actually rather not tattoo related uveitis? Is this TINU or tubulointerstitial nephritis and uveitis? But she had a completely normal serum beta 2 microglobulin, normal creatinine, blood, urine, nitrogen, urine analysis, normal kidney, no kidney symptoms. So, we still have her sent to nephrology, and that is pending, and maybe doing a DRB1. And for our PGY5s during the Royal College, HLA DRB1 is highly associated with TINU, a relative risk of 224, so that may come up on your exam. But is tattoo uveitis related to TINU? Did a quick review of literature, and really there's no papers that relate tattoo-related uveitis and beta-2 microglobulin or TINU. So this may be a very novel case. But what Dr. Dursko and I were discussing is maybe there's a third possible pathophysiology for this disease. We talked about the delayed hypersensitivity to the tattooing itself, patients with a susceptibility to sarcoid, but could those with underlying inflammatory predisposition, patients with positive inflammatory markers, have increased rates of uveitis and a delayed hypersensitivity to the tattoos, leading to a tattoo-related uveitis? And this is a real role for metagenomics, which is a whole talk in itself, where we can start analyzing some of the genomes in patients who are susceptible to this uveitis after tattoos, so we can better counsel patients. So to summarize, always include a history of tattoos in your review assistance for uveitis patients. Don't just say rashes, also specify if their tattoos have been inflamed. And this is probably, and tattoo-related uveitis is quite rare, but probably due to underreporting, and expect the prevalence to increase with the increasing rate of tattoos in our population. And this condition is highly associated with systemic sarcoidosis, so always screen for that in these patients. And there is a role for metagenomics in the future for patients with an inflammatory predisposition for this condition. Thank you so much.
Thank you very much. That was a fascinating case, and it's probably the first case I've seen of tattoo uveitis, but I know that Dr. Kaplan's seen a number of other cases. Do you have any comments, Dr. Kaplan, about your, I think you have a series of a few cases with tattoo-related uveitis.
Yeah, I have. I think I've seen about 7 or 8 over the last 5 or 6 years. I think the key with this is asking patients on review of systems about their tattoos, because especially in the winter when it's cold, patients are often, pretty bundled up, and they may not have so much exposed skin to think to ask. I think that's one point. The second comment that I have is the serum. Was it serum or urine?
Urine.
Urine. That's pretty interesting because, that I, in that's a finding you can also see in sarcoidosis as well too. They can get, an interstitial nephritis. So differentiating TINU from, true sarcoid can be challenging. And the fact that there was also tattoos elevated, is probably maybe more on the sarcoidy spectrum rather than just a hypersensitivity related to the ink. I actually haven't tested a lot of my older patients that had tattoo-related uveitis for serum and urine beta-2 microglobulin, but that's kind of an interesting kind of piece to add, and probably, maybe a good element to kind of add in terms of publication. But yeah, that very interesting case, great case.
Austin, I'm giving a talk next week at the Academy on keratopigmentation. In
Okay.
your review of I mean, we're using the same dermal dyes, sterile dyes, for photopsias due to iris defects. In your reading, in your review of the literature, did you see any cases related to corneal tattooing?
Great question. I only saw one case really, and it was more of an anterior uveitis that was chronic, and they thought it was a more of a chronic endophthalmitis that they from exogenous tattooing. Nothing that led to an actual skin tattoo inflammatory reaction, but really just more of the intraocular they characterized an endophthalmitis in their case.
Interesting. Great case. Great.
Thanks.
Thank you. So we're going to move on to the next case. Dr. Tina Tang is presenting our next dilemma in uveitis.
Good morning,
One of our
everyone.
fellows in medical retina and uveitis as well. So thank you, Tina. Sorry.
Thank you very much for having me this morning. So I'll be presenting diagnostic dilemmas in uveitis, lessons from 2 cases. Our first case is a 36-year-old male from Korea. He presented with flu-like illness with rash, vertigo, and visual disturbance. He was admitted at another hospital for 10 days and had an extensive workup by rheumatology, neurology, infectious disease, and they couldn't figure out any conclusive diagnosis based on their workup. He was otherwise healthy prior to this incidents and had no other past medical history. They consulted ophthalmology to assess for the visual disturbance. So on presentation, he had decreased vision of 2200 in both eyes with normal intraocular pressure. Slit lamp examination showed diffuse KPs and anterior cells of 0.5. On dilated fundus examination, you can see that there are scattered perivascular hemorrhages in both eyes throughout the periphery, and then also some superficial retinal infiltrates within the macula here, noted in both eyes as well. So whenever there are retinal hemorrhages, especially in the perivascular region, in a case of uveitis, it's really important to get an IVFA, as there could be features that you may not necessarily see just on clinical examination. So you can see here, this is the fluorescein angiography of the right eye. The left was the transit eye, so we have mid and late phase where you have significant peripheral capillary non-perfusion with diffuse capillary leakage, as well as large vein leakage and disc leakage in late phase. The left eye also shows throughout the early, mid, and late phase, there are areas of peripheral non-perfusion with diffuse capillary leakage and disc leakage in the late phase. So to summarize the clinical presentation, we have bilateral panuveitis with occlusive retinal vasculitis. This was the extensive workup that had been done through the previous admission. The blood culture was negative. They also did a lumbar puncture, which showed no signs of infection. CT brain and MRI brain were normal. They also did an extensive blood work with ANCA, rheumatoid factor, HIV, West Nile virus, syphilis, monkeypox, HSV negative. There were some tests still pending upon consultation, such as the quantiferon, Bartonella, Lyme, sarcoid, and lupus. But what other considerations or test results would you consider for this case? So it's important to remember for panuveitis with occlusive vasculitis. In cases of occlusive vasculitis, it's important to assess for lupus, but also really important to assess for Behçet's. And the patient ended up being positive for B51. And on review of systems, he also had oral ulcers. So the patient was started on treatment, including topical steroids, oral prednisone with taper, as well as infliximab. And also an important note for this case is that the patient also had neuroBehçet symptoms with his vertigo as well as balance issues, and he was diagnosed with bilateral vestibulo-ocular reflex loss. And it's really important to note that for Behçet's, with these neuroBehçet syndromes, early diagnosis and treatment is really important to help reduce morbidity, but also mortality. A bit about Behçet's disease. So it's a multisystem vasculitis. It was previously known for Silk Road disease as it involved the Mediterranean, Middle East, and Far East. But as more data is prevalent, it's more known as a global disease and it can appear in anyone. So for our patient, he was from Korea. It's mostly common in male and also more severely noted in the male in comparison to females. And the typical triad is described as oral ulcer, genital ulcer, and ocular disease. However, sometimes Behçet disease can first present in the eye, and so diagnosis is really important in terms of us knowing the clinical signs. And so this is a interesting review that was published in 2021, looking at just ocular signs of Behçet's and using that as diagnostic criteria for Behçet's without considering systemic features. So in table 1, it lists clinical features as well as fluorescein angiography signs, where they asked uveitis specialists to rate these clinical features as highly or fairly characteristics. And you can see that, our typical teaching of shifting hypopyon listed high. And then there are other important features like relapsing remitting nature of the inflammatory sign, transient superficial retinal infiltrates, and so forth. Fluorescein angiography signs, these 3 were found in our patient with diffuse retinal capillary leakage, retinal capillary non-perfusion, and also optic disc hyperfluorescence or leakage. The list that I made on the left side illustrates other clinical features of Behçet's, and those highlighted in yellow have high sensitivity, greater than 95%, and those highlighted in green are highly specific, greater than 95%. And from all of these listed clinical features and signs, the paper made this diagnostic algorithm to help in terms of stating whether the patient had no likelihood of Behçet's disease or high certainty, and using the top 10 items with high diagnostic odds. So they looked at vitritis, having granulomatous, no granulomatous or anterior uveitis or choroiditis were features of Behçet's, but having these would make it less likely to be Behçet's. And then these are other features that are highly specific and sensitive for Behçet's, including superficial retinal infiltrates, retinal nerve fiber layer defect, peripheral occlusive phlebitis, gliotic sheathing, ghost vessels, branch retinal vein occlusion, as well as diffuse capillary leakage on IVFA. And our patient, based on these algorithm, would be highly likely with Behçet's, just purely on ocular signs without any systemic sign into the algorithm. So going back to our case, so the patient was treated and followed regularly, and this is his 2-year follow-up. His vision had significantly improved to 20/20 from 2200, and you can see resolution of the retinal hemorrhages. The hypopigmented infiltrates are stable with additional pigmentation, but no new additional lesions. On IVFA, you can see there's still persistence of non-perfusion, but there's no significant leakage to indicate activity of the inflammatory component. So based on this IVFA, would you consider prophylactic laser in areas of non-perfusion to reduce the risk of NV, as there are significant areas of non-perfusion that are persistent?
So can we pause for a moment and we can ask for, can we go back to the fluorescein that you have there? And I think that Dr. Peaky has a couple of comments. So maybe we'll ask Dr. Peaky to comment on the fluorescein. And I believe he also had a comment about the OCT just before we go to the question about laser or not laser for this case.
Yeah, thank you. Thank you, Larissa. So this is a very typical case of Behçet, and a couple of things. When you present and mention the KPs, it's very important to say granulomatous or not, because you showed that beautiful algorithm by Ilknor, and that's what I follow, for example. So I'm sure in this case the KPs were non-granulomatous, and then I never get P51 because. I leave that to the rheumatologist. I just followed the algorithm you presented, and I was in Abu Dhabi, and that's Behçet is quite common over there, and the algorithm never failed me there. And you also showed some infiltrates on top of the retina, probably, and an OCT through those would have been great because those pre-retinal infiltrates, they're quite common in Behçet, and you showed it in your table. Just that my comments on this FA here, there's already telangiectatic vessels, and I would laser this because you never know, you may end up, so it's not about inflammation, but the ischemic retina may just produce more VGF. You may end up with a vasoproliferative tumor or more complication. I've seen this happen, so I would personally laser this.
Okay, so let's move on to, because there is some controversy in the literature. So Tina has some more information for us.
Great. Thank you very much for those excellent points. We did have an OCT, but it didn't necessarily go through those lesions. And they were non-granulomatous, fine diffuse KPs. So that is a really good point about an important feature for the diagnostic criteria. So in terms of the literature about lasering these areas of non-perfusion, so there are two main points that were highlighted in the literature. The first point being that immunosuppression and control of inflammation is priority. And so if you have NV in association with diffuse capillary leakage, that indicates that there's still persistent inflammation as the driving force for new areas of NV. And sometimes in those cases where there's high burden of inflammation, laser can worsen inflammation, and that could be a poor indication of lasering at the time. So initially first treating and having the inflammation under control with medical management before doing laser is an important point. And for our IVFA, it was quiet in terms of the inflammation. So the considering of laser is a possibility. The second point that was highlighted in literature is that usually studies reported laser for NV when it appeared, and also select cases of very high ischemic burden. There's not a lot of great randomized clinical trials regarding these studies, but some studies did recommend using laser for only eyes with retinal ischemia involving more than 2 quadrants. And then when NV did develop, a lot of the studies show that laser was really good in helping with regression of NV and also reducing the complications of neovascularization, including NVG, VH, and tractional retinal detachments. So for our case, we decided to monitor the patient initially. And after a year of monitoring, he did develop an area of NV as shown here on IVFA. And so the patient is planned for laser. The second case of diagnostic mystery is also a Behçet's case, but there are some important points to highlight as well. So this patient was a 51-year-old female who was a Canadian physician who had malaise and joints pain that presented during COVID pandemic. And so the patient didn't have typical demographic of Behçet. She was female and Caucasian. She was also admitted at a peripheral hospital and had extensive workup with no diagnosis made despite the extensive workup. She had MRI brain showing diffuse white matter lesions. And when she came to ophthalmology for consultation on review of systems, she also had oral genital ulcers. and she did test positive for B51 and was started on adalimumab. The teaching point for this case is that she also ended up developing areas of NVE, and she received laser. And sometimes even with laser, you may need multiple sessions to ensure that you cover the areas of ischemia with follow-up IVFA. And if there are additional areas of NVE that develop later on, you can repeat and supplement the laser, even if there are no signs of active inflammation. So this patient had supplemental laser, which helped reduce the leakage of the areas of NVE. So the main teaching points from this talk is that it's really important to do a good review of system in patients with uveitis, as sometimes the ocular presentation could be the first presentation of the systemic condition, and we can have a really important role in helping with diagnosis. And early diagnosis and treatment is really important, especially in neuro-Behçet's disease, as it can be life-saving, and both those patients that we had neuro-Behçet symptoms. Third is that Behçet's can present in a variety of patients, even outside of the typical demographic. And so it's still important to have that on your differential, even if it doesn't typically follow the Silk Road demographic. And then lastly, treatment of ocular Behçet's. We went over the acute management with systemic control of the inflammation with steroid and immune modulating therapy, but also the chronic management of potentially what to do in those areas of ischemia, and also if they end up developing neovascularization. Thank you very much.
Thank you very much, Tina. So that was a very interesting case because the patient really had extensive workup. He was admitted at another hospital. They didn't figure out what the etiology was. And really it took, the patient came to the uveitis clinic, and that's where we made the diagnosis. So always important to think about Behçet's and of course do a full review of systems in all cases. So Dr. Walid Asarhani is going to present our next case. Walid is our chief resident of ophthalmology in the program, and we will pause for some questions as well during the case.
Okay, so I'd like to take the chance to thank Dr. Dersko for her kind supervision throughout the preparation of this case. So this is a 37-year-old woman who presents with decreased vision in the right eye for 2 weeks. Prior to that, she had visited an optometrist who noted the presence of retinal scarring, and on past medical history, she had iron deficiency anemia. She was born in India. She's non-smoker, denies any alcohol use, and on review of systems, everything was negative. No skin rashes, no joint pains, no ulcers, no fever, night sweats, no neurological GI symptoms, no history of eye trauma, no tattoos, or any of that. On physical examination, the vision in the right eye was 20/60, in the left eye it was 20/20. IOP, corneas, anterior chamber, and lenses were normal in both eyes. The anterior vitreous had 1+ cells in the right eye, but not in the left eye. So this is a fundus photo that shows the presence of multiple chorioretinal lesions distributed throughout the fundus, extending from the posterior pole all the way to the equator. And IVFA, as you can see, shows the presence in the early phase, in the late venous phase, multiple transmission defects, window defects. Along in the late phase, in the recirculation phase, there are multiple new hyperfluorescent lesions. The window defect lesions, you can see the presence of a hyperfluorescent rim around them. This is the left eye, again, a late frame that shows the presence of multiple hyperfluorescent spots, and in the window defects, you can see a hyperfluorescent rim surrounding them. OCT image, the left eye was completely normal. In the right eye, you can see loss of the ellipsoid zone noted on OCT. Workup shows it came back negative for angiotensin converting enzyme for syphilis, and chest X-ray was also normal. These workup testing were requested by an outside ophthalmologist who had seen the patient before she presented to St. Michael's emergency. So what would you do next? Sandra, if you can pull up the first poll question. So what would you do next? Would you request quantiferon testing, start oral steroids, start Durezol, or inject intravitreal dexamethasone?
Thanks, Waleed. We'll give that just a minute to run. We're starting to get some answers in there. There you go.
Okay, so yeah, most people chose to go for quantiferon testing. So quantiferon was requested, and Durezol was started as well. In fact, the quantiferon testing took some time. Patient took her time to do the testing. She was seen in the ID clinic, and infectious disease cleared her to start prednisone. So prednisone 60 milligram, 1 milligram per kg per day was started. And quantiferon a couple of weeks later came back positive, and she was on prednisone tapering regimen, 40 milligrams that day. Best corrected visual acuity in the right eye improved from 20/60 to 20/20. So the question is, this takes us to the second poll question. Would you start anti-TB treatment? And the choices are no. B, yes, you're going to start latent TB treatment, or you're going to start full anti-TB treatment.
You know, this is a good question. We're starting to get a mix of responses. So I'll share this with you in a second here.
Okay, so we have a mix of responses between latent and full anti-TB treatment. Patient was seen in the TB clinic again, and the patient was started on full anti-TB treatment, quadruple therapy for 2 months, and then for the next 4 months, it's going to be reduced to only 2 medications. So third poll question, what supplement are you going to give, or you should give, with isoniazid? Is it vitamin C, folic acid, pyridoxine, or vitamin B12?
I'll give that just a couple more seconds there, Waleed.
Okay, so we have a mix between folic acid and pyridoxine. The answer is it's vitamin B6. The pyridoxine should be given in patients receiving isoniazid to prevent peripheral neuropathy. So the patient was seen at month 2. She was on prednisone 20 milligrams. Best corrected vision remained 20/20, and there is no new lesions. Month 6, she was stable, and month 9, which was the last visit, she was on prednisone, very small dose of prednisone, 2.5 milligrams, no signs of new lesions, and best corrected visual acuity remained 20/20. And this is her OCT on day 1, and this is the OCT on the last visit. And you can see there's some reconstitution of the, yeah.
Pause for a moment,
Sure,
and let's get somebody
course.
to describe the OCT, the changes in the OCT.
I can describe it.
Sure.
So when compared to the OCT on presentation, you can see some mild recovery of the ellipsoid zone, possibly when she started treatment. So that's the main thing I see. I also see ripple, like RIPL, like just that along the inner middle layers of the retina from the ellipsoid zone loss.
Excellent.
Sorry, can I mention something? There's in the baseline OCT, you can see that under each area of ellipsoid loss, not really loss, but where it's reforming, the choriocapillaris is still intact. So that's why you have the ellipsoid coming back with treatment. So I think in these cases, it's also very important to get either an OCTA and look at the choriocapillaris or an ICG. So it's beautiful OCT at baseline, and the choriocapillaris is intact.
And I was going to ask Dr. Peaky, what do you think about, there's a little bit of hyperfluorescence in the choroid there. That is one of the things that's described in TB uveitis. Do you think that's relevant just under the area of the ellipsoid zone abnormalities?
Yeah, it could be, because probably those are still vessels that are still active. I'm not sure. I don't look for that usually. But yeah, I look for the choriocapillaris under the intact ellipsoid. And I think an OCTA here would have been great, because it would have shown a lot of stuff, a lot of perfused area still ongoing in the choriocapillaris.
Okay, thank you.
Okay, excellent. So, and this is the last fundus photo that shows the presence of stable chorioretinal lesions, and there was no appearance of new lesions. So the diagnosis was TB serpiginous-like choroiditis. So for presumed intraocular tuberculosis, the criteria the diagnosis has to meet all three criteria. Findings suggest like consistent with possible TB with no other causes of uveitis suggested by history or exam. And the second thing, there has to be strongly positive TB testing or radiological evidence of healed or active TB lesions and a positive response to anti-TB treatment. On the other hand, definite intraocular tuberculosis is very hard to diagnose because you need a definitive diagnosis of TB in the ocular fluids, whether it's by demonstration of acid-fast bacilli by microscopic examination, or a positive culture from the ocular fluids, or positive PCR. So this takes us to the last poll question. What is the most common manifestation of presumed intraocular TB? Is it anterior uveitis, intermediate uveitis, retinal vasculitis, or disseminated choroiditis?
I'm going to give that just a couple more seconds, Waleed. We're starting to get some responses here.
Okay, so most people are going for disseminated choroiditis. So the correct answer is the most common presentation of ocular TB is disseminated choroiditis and tubercular choroiditis. So as you can see, these are different manifestations of TB choroiditis. In photo A, you can see the presence of serpiginous-like lesions in the posterior pole, and in photo B, you can see multifocal choroiditis. C, it's a unifocal choroiditis, and in D, you can see a choroidal tuberculoma, which is a yellowish subretinal lesion with indistinct borders and surrounding exudative fluid. So this is from the literature. You can see an early IVFA that shows the presence of hypofluorescence around the macula, and then in the late phase you can see some hyperfluorescence, and this is consistent with serpiginous-like choroiditis. This is another manifestation of TB, which is optic neuritis or neuroretinitis, and another manifestation of TB here is retinal vasculitis or occlusive retinal vasculitis, which is primarily periphlebitis, which involves veins rather than arteries, and it presents with perivascular sheathing, retinal hemorrhages, ischemia, and devascularization. So TB can also affect the anterior segment. It can cause granulomatous anterior uveitis. However, non-granulomatous uveitis can be seen, and it can cause intermediate uveitis, snowballs, vitritis, complicated by macular edema too. So what are the indications to start anti-TB treatment in TB choroiditis? So if you have serpiginous-like choroiditis, and this is based on the collaborative ocular TB study guidelines for TB choroiditis, and this was based on the input of 81 global experts, and this included ophthalmologists, pulmonologists, and infectious disease specialists. They generated a preliminary consensus statements for initiating anti-TB in TB choroiditis. And basically, if you have a serpiginous-like choroiditis, then the indication is definitely to start anti-TB treatment if you have either positive TB skin testing or positive interferon gamma release assay. And in TB, in choroidal tuberculosis, which also has strong association with TB, you need positive immunological testing, whether it's TB testing or TB skin testing or interferon gamma release assay. However, in endemic countries, you need positive chest X-ray or positive CT of active or healed lesion to start anti-TB treatment according to the consensus. And finally, if you have unifocal or multifocal choroiditis, this has weak association with TB, and therefore, in addition to positive immunological testing, positive TB skin testing, and positive interferon gamma release assay, you need positive radiological evidence of active or healed lesion. Steroid treatment, the previous study reported a favorable response to anti-TB treatment when given simultaneously with systemic steroids in patients with presumed TB uveitis. And in terms of immunosuppressive treatment, if patients develop relapses while on steroids, then immunosuppressive treatment may be indicated. For retinal vasculitis, again, retinal vasculitis has a weak association with TB, and according to the consensus, weak consensus was achieved for starting anti-TB in non-endemic areas. However, in endemic areas, you may start anti-TB treatment in the presence of positive radiological testing. And this is a summary of what we mentioned about treatment. Again, if you have serpiginous-like choroiditis or choroidal tuberculoma, these two manifestations, they have very strong association with TB, and therefore you only need positive PPD or positive interferon gamma release assay to start anti-TB treatment according to the consensus. However, if you have multifocal or unifocal choroiditis, you need positive radiological evidence in order to start anti-TB treatment. And if you don't want to memorize this, this has been entered into a calculator, the Collaborative Ocular TB Study Calculator. And when we enter our patient's details, the patient had serpiginous choroiditis, the patient came from an endemic country, had positive interferon gamma release assay, and chest X-ray was negative. So the consensus suggested that we should consider starting anti-TB treatment. So in summary, TB can cause any type of uveitis, most commonly disseminated choroiditis. It most commonly causes granulomatous uveitis. It most commonly causes posterior uveitis, serpiginous, choroidal tuberculoma. They have to be treated with anti-TB treatment, even if you have a negative chest X-ray. You can consider anti-TB treatment in unifocal or multifocal choroiditis only if chest X-ray or CT is positive for healed lesions. Thank you so much.
Thank you, Bully. That's an excellent presentation. So one of our challenges with TB is we can't get tissue samples in positive kind of microbial samples. Even if we do a vitreous biopsy, the yield is quite low. So our question is whether we treat with full anti-TB treatment or whether we're going to treat with latent TB treatment. So that's always the question. So again, serpiginous choroiditis is where we would do always full anti-TB treatment. And the other types of choroiditis or vasculitis, we need a positive IGRA or a TB skin test, as well as positive imaging. So we are going to move on to the next case in the interest of time, and Olga Boginskaya will be presenting our next challenge in uveitis.
Thank you for the opportunity to present. The case is a 55-year-old male with a blurry vision in the left eye more than the right eye. He underwent a cataract extraction in both eyes with improved vision. However, in summer 2021, he presented with blurry vision and seen bright spots in the left eye. He was seen in uveitis clinic with a vision in the right eye 20/30 and the left eye 20/100. His fundus exam was unremarkable on the right eye. However, the left eye, the view was obscured because of significant vitreitis with no lesion seen. Similar features was observed with the autofluorescence. His IVFA in the right eye was essentially unremarkable, maybe with some areas of hyperfluorescence at the late stages after 5 minutes. The left eye, despite the hazy view, we can appreciate the hyperfluorescence along the arcades, which increase going down the IVFA and the hot licking optic nerve. However, there are no leakage or no staining that would be pathognomonic for inflammatory disease. His OCT was essentially unremarkable, with preserved foveal contour and preserved inner and outer retinal layers. But if we will have a look at the heat map, we can appreciate that on the right eye, there is some elevation of the fovea, some thickening of in the fovea. And here it comes the first poll question. What would be the differential diagnosis of the vitritis in the middle-aged man? Is it ocular fog syndrome? Is it inflammatory disease, masquerade syndrome, or maybe it's sleepless night during the PGY2 or any infectious causes?
We're just going to give that a second there, Olga.
Yes, great. So most of them two infectious causes. Exactly. So a little bit about patient's history. He was originally born in Grozny, Chechnya, and relocated to Georgia for 6 years, then moved to Canada and had frequent visits to Russia, which is considered endemic area for many infectious disease. His past medical history is known for latent tuberculosis, and he received treatment for that. No current medications, no allergies, no comorbidities, no immunosuppression. He's former smoker with no alcohol or recreational drug use. His workup was essentially negative except for positive quantiferon. He was seen in TB clinic with negative induced sputum and cultures, and he did not require any treatment. Notably, his MRI brain was negative at that time. So he was started on topical treatment of prednisolone, and unfortunately, he lost to follow-up. There was a fragmented care in our clinic. A few months later, he presented with a decreased vision in the left eye at hand motion with no improvement with a pinhole. Anterior segment demonstrated diffuse small pigmented KPs with a trace AC reaction and significant vitritis more on the left side. So the impression we had was anterior uveitis with intermediate uveitis and vitritis more prominent on the left side. His right eye OCT demonstrated still normal findings, and there were no view from the left eye. In summary, we have a middle-aged non-compliant patient with persistent vitritis, negative review of system, and workup. What would be the best next step? This is the second poll question. Start systemic corticosteroids, involve rheumatology, maybe do some tissue sampling, or proceed with the intravitreal injections.
Always a challenge in these cases. So it looks like most people want to involve rheumatology, which makes a lot of sense.
Yes, but we did a little bit differently. We proceeded with a tissue sample. So he underwent a left 33 gauge pars plana vitrectomy, and his results came back positive for large B-cell lymphoma and negative viral and acid-fast bacillus test. The gold standard for vitreoretinal lymphoma diagnosis currently is cytology that helps us to identify the abnormal large B cells. However, there is a high false negative rate in such diagnostic tests because clinically, even though we see lots of cells under slit lamp, when we perform HCTAP, the number of cells is not sufficient to perform the diagnosis. However, if any of these cells are found, immunophenotyping is very helpful to differentiate the subtype of cells. Is it T, B, or NK cells? B-cell lymphoma is the most common. The next one, diagnostic test, which is also useful to differentiate malignancy versus inflammatory cases, is cytokines profiles. B-cell lymphoma produce interleukin 10, and therefore we have a higher ratio of interleukin 10 to 6. Patients with the B-cell lymphoma have a higher level of soluble VEGF and interleukin-2 receptors. And finally, the most important test is genetic tests, next genetic sequencing, which help us to identify specific mutations in the specimen, even though we may not have enough cells for that.
Can we pause for a moment, because Dr. Altamari is on the panel here, just with regards to testing here in Toronto and what we have available. We've had some discussion about that in the last few days.
Yes, the primarily it's actually cytology that we rely on more than anything else. The cytokines ratio has not really been that reliable. We really don't use it. The MYD88, which is the most common mutation that we see, is actually being done, but there's a little bit of a nuance to it. The current facilities will only test MYD88 in situ. That means they actually have to see a cell and then test that cell for MYD88. Now, there are some reports of looking at like cell-free DNA of MYD88. And in some cases, it actually turns out positive even though you may not see any cells. The issue with in Toronto is that you need a high amount of DNA in order to do so. That's why they rely on cells. So mid-88 cell-free DNA, that would be great, but that test is currently really not available, one because of yield, and the second because it still needs to be validated as a reliable test itself. But the current classifications, when we look at lymphomas in general, do include mid-88 when you can test for it.
Thank you very much. That's very good to know.
One final thing I would just add, sorry, is that if you're taking a sample in the clinic, what I found very helpful is to actually have the tech to process the sample as soon as they take it out of the eye. And I found that actually can increase the yield, especially when I do it at Princess Margaret Hospital. Thank you.
Thank you, Dr. Aldemar. Because the patient biopsy came positive for malignancy, we decided to repeat the MRI, and at this time MRI demonstrated multiple lesions in the brainstem, cerebellum, and both hemispheres. So his diagnosis was established. The patient had primary central nervous system lymphoma with bilateral ocular involvement. Important to notice that 36 to 90% patients with vitreoretinal lymphoma develop CNS involvement, and that is why early detection is so important, while just 11 to 37% of primary central nervous system lymphoma develop vitreoretinal lymphoma. The pathophysiology of vitreoretinal lymphoma can be explained by two mechanisms. First one is hematological spread, and this is supported by the fact that the lymphoma B cells have a specific receptors that match the chemokines produced by RPE. And the second one is the infectious theory. When lymphoid cells present in the eye undergo malignant transformation under the effect of some viral agents. The most known association is Epstein-Barr virus and the immunocompromised patients. The current treatment modalities include topical chemotherapy, systemic chemotherapy, external beam radiation, and targeted therapy based on the type of the mutation patient has. So back to our case, the patient was successfully treated with chemotherapy, underwent bone marrow transplantation, and was negative for quite a while. However, there was fragmented ophthalmic care due to COVID and missed visits. At the last visit we saw him, there were no findings on the fundus exam, autofluorescence. His OCT looks perfectly normal. But a few months later, he presented with decreased vision in the right eye this time, with mild AC reaction and OCT findings, which are consistent with the subretinal lesions with the horizontal distribution, some disruptions of ellipsoid zone, preserved Bruch membranes, and intact choriocapillaris layers. Unfortunately, we couldn't find it. I found this picture at that time, but even on the OCT infrared picture, you can appreciate some granularity and kind of leopard pattern at the fundus pictures. His visual acuity was hand motion, and he again developed some vitritis at this time at the right eye. The pathognomonic features for vitreoretinal lymphoma, it is a discrepancy with the degree of vitritis and the visual acuity, significant involvement of the posterior camera with the vitreous inside, quiet eyes despite the inflammatory reaction. Vitreous body may exhibit also specific patterns of lymphoma cell infiltration. However, non-specific case is the most common one. Back to our patient, in his right eye, now we can appreciate the typical leopard pattern demonstrating hyperpigmented areas with a hypopigmented foci representing the reaction of RP to lymphoma cell infiltration. Chorioretinal scars can also be appreciated. In the right eye, after a pars plana vitrectomy, the left eye after a pars plana vitrectomy is completely normal. The typical lesions are well described in lymphoma occasion. However, it is one of the great masquerade syndromes that can mimic chororetinitis of other different regions. The autofluorescence pattern represents leopard pattern, granular pattern, and chororetinal atrophy. OCT typical features include horizontal spread that suggests infiltrative disease and outer retinal layer disruption as well. Overall, OCT features can be divided into findings into the vitreous, which we already discussed, present the cell infiltration, the retinal findings, pathognomonic vertical lesions representing infiltration through all the layers, and RPE changes, including subretinal vitelliform lesions, thickening RPE, sub-RPE infiltrates. IVF patterns can mimic the similar hyper and hyperfluorescence patterns resembling leopard pattern on the eye fundus. However, the most striking feature is that lymphoma will not, although can, but will not represent inflammatory features such as significant leakage, significant staining, and SIMI, although also possible. The patient underwent MRI that demonstrated a new lesion. So overall, we have a relapse from ophthalmology and neuroimaging perspective, and however, no neurological symptoms. In this situation, we decided to proceed with the AC tab, and his recent vitreous tab demonstrated no malignant cells suspicious for lymphoma. And the question would be, should we rely on the clinical presentation in this situation and treat this patient as a relapse of lymphoma, or do we need to request for more tissue sampling? In any case, these cases are frequently considered as palliative, and one of the option modalities for him will be brain radiation therapy or intravitreal chemotherapy. I will just skip it for the safety of time. And these are my references. And thank you so much for your attention.
Thank you very much, Olga. These are cases that are always challenging, but we always have to remember that patients middle age, over 50, with new onset vitritis, we should be considering masquerade syndromes or vitreoretinal lymphoma as a possible etiology. I think I'll let, if Dr. Altomare has any final comments in this case, he's our expert in vitreoretinal lymphoma here in Toronto.
Yeah, in this case, the changes in the right eye were actually quite dramatic when you compare it to the 2022 pictures. And from a clinical sense, I felt this actually represented intraocular lymphoma. And that, for me, would be enough to go ahead and treat it. The issue becomes from the oncologist systemically, depending on the burden of the chemotherapy they may need to use, they often will want to have a tissue diagnosis. The problem I've found about tissue in this eye is that a lot of the changes were atrophic and the actual yield will be less. But if I can actually identify any cells, whether subretinal, choroid, retinal, we can easily take tissue in each of those planes and actually increase the actual yield. So we did a vitreous tap because it's very low risk, and if something was positive, great. But still clinically, I felt this was more consistent, especially with the MRI imaging of a relapse.
Thank you very much. Thank you to all our residents and fellows for presenting today. Those were complex cases and illustrates what we do in the uveitis clinic, but they're fascinating cases. And thank you also to our panelists this morning, to Dr. Pichi and Dr. Kaplan, Dr. Altomare. And I think Dr. Rai will finish up the rounds.
And thank you, Larissa. Those were fantastic rounds. I said at the beginning this morning that this is one of the most popular rounds of the year, and you guys definitely delivered. So thank you to our residents and fellows and Dr. Dersko. And for our audience at large, once again, I'd like to welcome Dr. Francesco Pichi to the University of Toronto and our Toronto community. He'll be seeing patients at Kensington, Sunnybrook, and St. Mike's just after the academy. So it's always good to have more uveitis help in the city. Thank you for all that you guys do. And Larissa, thank you for all those interesting cases this morning. We won't have grand rounds next week because of the academy meeting. We'll resume in 2 weeks with Dr. Victoria Leung. Have a good day, everyone.
Well done.
Thank you,
Best, everyone.
Thanks. That was great. Thanks, Emma-Dave.
Yeah, no, that was that's always the most popular rounds of the year. I was a little worried about time, but you guys did great.
Yes, yes, I know. I wish we had more time because we could have talked a lot more about the imaging with Dr. Peaky and so on, but we'll